Great, so wonderful. So thank you, Dr. Moreno, and I really want to thank Doctors Kinney, Sharma, and Moran for inviting me here. It's been gone for a few years, and it really is special to be back in New York with friends, colleagues, and my mentors. Dr. Chiporia has done just an amazing job, and I've got to confess, I essentially agree with her points, so I have the unenviable task of hopefully convincing or at least providing a rationale for why our current guidelines and societal recommendations are a bit more restrictive in how we deploy both IVUS and OCT. These are my disclosures. Now I'm going to start off with a framework and a couple of points that in 2025 are really not up for debate any longer. Point number one, I think we all can accept that intravascular imaging certainly improves the efficacy of PCI. This is principally by reducing TLR and TVR. I think we can all agree that intravascular imaging enhances the safety of PCI, reducing target lesion MI and stent thrombosis. And as Dr. Chiporia just mentioned, procedural risk is certainly not prohibitive. There is an upfront cost that is incurred. And so the debate, to the extent one exists, is really centering around whether we should be a bit more restrictive in utilizing these tools in those patients and lesions most likely to sustain ischemic events post-PCI. And I'll try to support that premise by reviewing a few of the trials that have substantiated the benefits of IVUS and OCT and illustrating that they really have enrolled high-risk patients and lesions, illustrating some data that shows the variability in clinical benefit as a function of patient and lesion risk, and then finally, the financial calculus, which is again driven really by patient risk and the perceived magnitude of benefit. So let's go through a study, Renovate Complex PCI. So this is a trial conducted in Korea that compared intravascular imaging predominantly with IVUS use versus angio guidance. And in this trial, the authors define complex lesions or PCI's true bifurcations, long, severe calcium, ISR, multivessel PCI or CTO, about 50% presented with ACS. No question, these are high-risk patients. And after a 3-year follow-up, you can see that the primary endpoint of target vessel failure is significantly reduced in absolute terms by almost 5%, relative terms almost 40%, and you also see about a halving of risk in cardiac death and numerical reductions in target vessel MI and TVR. So very positive result. What about OCT exclusively? Here are the data from the European trial, the October trial, which compared OCT versus angio guidance. Now this is again complex lesions, this is complex bifurcations, and left main bifurcations were actually 20%. Side branch stenting was needed in 2/3 of these patients. And over a 2-year time period, you can see the primary endpoint of MACE, which is really target lesion failure, was again reduced by a large 4% absolute risk reduction, relative terms 30%. Some excess contrast and procedure time with OCT, but certainly not sufficient magnitude to mitigate any benefits. Another nice positive result, again, highlighted in complex lesions. Now, as has already been mentioned earlier today, is the ultimate trial, from which we, of course, get the ultimate criteria. Now, this was a trial comparing IVUS versus angio in a quote-unquote all-comer cohort. I put that in quotations because if you actually look at the features of these patients from a lesions perspective, about 2/3 were AHA B2C, average stent length was 50 millimeters, and that perhaps is just a reflection of the reality we live in today in the contemporary PCI era, where the majority of patients actually will fulfill some type of complex lesion definition. And in these 3-year data, you can see the primary endpoint of target vessel failure is again significantly reduced by IVUS, again about a 4% in absolute terms, 40% relative, and also significant reductions in stent thrombosis. So these trials and others similar to that have really demonstrated the clear benefits of these technologies, but again, in high-risk patients and lesions. Now, what about insights on the variability of benefit in relation to patient lesion risk? Do we have any data to suggest we'll get more benefit in higher risk patients? Well, we do have some insights. So here are 2 trials comparing the exact same strategies. On the left is October, OCT versus angio. On the right is Illumian 4. Both of these trials, again, comparing the exact same strategies, both of these trials recruited, enrolled, and followed up patients in a time period that overlapped with the COVID pandemic. And both trials had almost the exact same endpoints, target lesion versus target vessel failure. The big difference in these trials was whereas the October trial focused on complex bifurcations, Illumian 4 was a bit more heterogeneous in the types of patients they included, diabetes or complex lesions. And you can see that in these trials, the control event rate in the October trial was right at 14%, yielding a large reduction with OCT, whereas in Illumian 4, the control event rate was 8%, yielding a non-significant result with OCT. Now, there are many other cited reasons that perhaps led to the null result in Illumian 4, but as the accompanying editorial suggests, I think we can't ignore the fact that the difference in outcomes was certainly maybe related to the types of lesions included in each trial. Now, again, this is a between-trial comparison. What about a within-trial comparison? So this is, or these are data from a post-hoc analysis of the ultimate trial at 3 years. And what the authors did here is examine the event rates in IVUS in vertical blue versus the angio guidance in vertical red in relation to procedural complexity that was defined, as you can see at the top of the slide. And you can see on the left a clear reduction, about 5% in absolute terms, significant subgroup p-value. And now on the non-complex on the right, again, there is a benefit. It's just much more modest, and at least in the subgroup, p-value is non-significant. So we see at least some insights that there is a variability of benefit in relation to patient and lesion risk. And for these reasons, we see a consistent theme that is being articulated across societies and recommendations. ESC giving a class 1 for IVUS or OCT in left main true bifurcation long lesions. The ACC Interventional Council in their paper does promote and strongly advocate for the use of intravascular imaging, but again, as an essential adjunct for specific lesion subsets. And then finally, the most recent iteration of the ACC-AHA ACS guidelines, a class 1 recommendation, again, predicated on left main or in complex lesions. Now, what about the financial calculus? This is something that kind of, I think, makes us a bit uncomfortable. We don't like to think about finances impacting what we do, but the reality is they certainly do, and we have to understand where these costs originate and how we can get cost effectiveness or benefit. So when it comes to these technologies, obviously there is an initial capital outlay. If you want to install any one of these technologies, there's a significant upfront cost, which does render some labs unable to have both and some to not even have one. Every time we use one of these catheters, there's a cost there. We all know that when we use IVUS or OCT, what we're ultimately doing is either using more or larger balloons or perhaps adjunctive devices, which add additional cost. And at least in the U.S. healthcare system, these upfront costs are unfortunately not reimbursed. They are borne by the hospital or the cath lab, whereas the financial benefits are realized by the payers downstream. Now, from a societal perspective, this may be really just fine and not a problem, but this framework and this construct is certainly not ideal when you're trying to run a lab or a hospital department. And as Dr. Chaporia mentioned, we do have cost-effectiveness data. So these are data from the Renovate Complex PCI trial. Again, these were high-risk lesions and patients. This is from the Korean healthcare perspective. And as you can see in this simulation, in this graphic, after about 7 years, the cumulative costs in the angio arm in red begin to exceed the cumulative costs of the IVUS-guided arm in blue. Now, in this simulation, this cost-effective analysis, like any others, are essentially predicated on some key assumptions. And one of those assumptions is, what is the event rate in the population that you're studying? What is the durability of benefit? And what's the magnitude of benefit? And in the accompanying editorial, the authors highlight that the rates of mortality in MI have the largest effect on any cost-effectiveness. Again, standing to reason that it's those patients and lesions where we're going to get the most benefit. Now, finally, perhaps we don't need to be debating, should we be using IVUS or OCT in complex or non-complex lesions? I completely agree with Dr. Chapuria's point. We're simply not using these technologies enough. Even if we made the bar complex lesions, we're nowhere near that. This has been cited in multiple studies. These are data from the National Readmission Database looking at over 1,600 hospitals, 1.3 million procedures, and you can see In the vertical blue, that illustrates the profound, substantial variability in IBIS or OCT use across hospitals. Only 15% of PCI procedures were guided by intravascular imaging, and what was really insightful in this analysis is that the authors controlled for patient level, procedural level, and hospital factors, and there was still a four-fold variation in use, indicating that it's something about us as operators, perhaps training, perhaps lack of comfort, perhaps perceived other barriers that I think is really the call to action, as has been mentioned. And I think the authors' points are exactly on correct, that their results highlight the need to improving adoption, training, and application of intracoronary imaging to guide PCI procedures in the United States. So I don't know if I won the debate, but hopefully when I go home, my son will at least think I did. So I'll end there. Thank you.